TopMedTalk.
This piece is presented by Dr. David Voellinger, lead physician at Novant Health Bariatric Solutions in Charlotte, medical director of Novant Health Bariatric Centre, and the chief of the Department of General Surgery at Novant Health Presbyterian Medical Centre. Have a listen.
Morning, everybody. Ty, surgeon. Happy to be here. Happy to talk about our data. I think we have a lot of, we have to pay a lot of respect to our anesthesiology and colorectal colleagues that have blazed this trail. Those of us in other specialties, Dan, our cardiac surgeon, Jimmy is a bariatric surgeon, have a lot of work to do to catch up with what y'all been doing the last couple of decades. So we're trying to catch up. We're all in, we're believers. As I'm going to say at the end of my talk, and I'm going to start at the beginning, if enhanced recovery is not standard of care, we're doing something wrong. It's where we need to be, and I think that's where we want to start. So, disclosures aren't related to what we're talking about today. Where we come from, just give you a little idea of what our facility looks like. We're, number one, fortunate to have Vicki Morton as our ERAS coordinator. So we're way ahead of the game right there already. But we do have a system-wide program. I work for Novant Health, which is a health system for Virginia to Georgia. We have 5 hospitals. Each hospital has a steering committee on a system, market, and hospital level that helps with our ERAS program. We're doing about 1,200 bariatric ERAS cases a year. Protocols are up for review yearly. Hugely important quarterly data review is one of the things we're going to talk about, is some things we picked up in reviewing our data that allowed us to revise our protocol positively. Our protocol changes are all reviewed by committee, not by the individual surgeons who would like to come and do this and that and this. It needs to be run by the committee to make sure that we're all on the same page. And that happens on a lot of things. We mine our data, look at the trends, information that we gain from other service lines, from our colorectal colleagues, our GYN colleagues, our plastics colleagues. Literature review, certainly as more literature comes out, although as I will tell you, there's an extreme dearth of bariatric ERAS information that we hope to change. And then looking at clinical research projects that we'll also touch on. It's got to be multidisciplinary patient care and education in all areas of the hospital. If you're not doing multi-departmental work, you're not doing enhanced recovery. Period, end of story. It's not an anesthesia surgeon issue. It is a hospital-wide, inpatient, outpatient, ambulatory acute issue. And patient education, we'll touch on that a million times. It is not enhanced recovery if there is not a patient education component. And we are very blessed in our particular situation to have nurse navigators. And our nurse navigators is a really important component because they educate our patients in pre-op classes. They round on our patients in the hospital. They follow with our patients post-operatively. So they're really the linchpin to what we do for patient education, helping our patients understand what they need to do and most importantly, why they're doing it. Briefly on why would we do ERAS and bariatrics to start with. As we thought about this around 2016, we don't need to do this. Our patients go home in a couple of days, right? They do pretty well. They don't, have a tremendous amount of pain. We're doing everything laparoscopically. Don't have a lot of wound hernias, wound infection. Recovery time looks pretty good. We got a lot of patients with chronic pain. I mean, we got a tremendous, in bariatrics, as you can imagine, operating on a guy 650 pounds before I came here. And, there's some pain involved, right? They're going to be on some opioids. Why would we go opioid free? As our anesthesia colleagues can relate to, tap blocks aren't extremely easy in a 650 pound guy. So that's, if we were already kind of thought we were doing enhanced recovery because we were using E-Man, man. We're doing enhanced recovery. We're giving them E-Man. That's, we're doing great. In the colorectal literature, my friend Tony here is definitely a colorectal anus guy. Well, I'm up here, esophagus, right? There's a different deal. So the upper GI is certainly different than lower GI. And in being in the bariatric world, we were already all in on patient education. It's what we do. We teach our patients throughout. So it's something we were it was always, as I said yesterday, kind of baked into the cake of bariatrics. But we did have things we thought, well, here are some areas we can improve. Certainly pain at the extraction site, from a sleeve gastrectomy, our surgeons that do EEAs for their gastric bypasses. We take out band ports, there's pain. Could we potentially take our gastric bypasses down from a 2-day hospital stay? Yes, we have a high incidence of sleep apnea, atelectasis, respiratory depression, so all of that certainly is affected by opioid use. One of the biggest, and this was probably the biggest thing we wanted, why we took on enhanced recovery, was our high incidence of post-op nausea and vomiting in our sleeve gastrectomy patients. Any of y'all who have bariatric surgeons in your hospital know what I'm talking about. The sleeves definitely tend to have a higher incidence of nausea, vomiting. And then there was a whole lot of, while there was not a lot of literature, the literature that was out there in our review said, yeah, the trend is certainly positive, so we're doing enhanced recovery. So we started. We developed our protocols, we developed our program. In our system, the colorectal program started first. The data was there, the evidence base was there. They blazed the trail, worked through some of the kinks, and then we got on board February 2017. How we established our protocol, and this is certainly a lot longer conversation, but just briefly, we looked at the things that were out there. The two biggest things were the ERAS Society guidelines for bariatric surgery and a group from Cleveland Clinic Weston, Raul Rosenthal's group, who developed a checklist based on their review of the literature. So we used what our colorectal surgeons were doing in our own hospital and then added some bariatric touches based on what we saw in the literature, which is how we developed this. I'm going to read through this word by word. And so as in all enhanced recovery programs, we're looking at both preoperative, pre-op unit, intraoperative, PACU, floor, discharge. So again, encompassing all the different levels, different departments is crucial. So what do we change? This may be into the weeds a little bit, but it kind of gives you an idea of kind of the things we were thinking about and what we did as we developed our protocol. We were of the pain-free at all costs school of thought initially, right? We were morphine PCA people, believe it or not. We completely took those away. That saved us a tremendous amount of problem with opioids and saved us a lot of money. So we went to IV acetaminophen, Toradol, gabapentin. Again, we still stuck with our EMAN, using Zofran. We were using EMAN, but we had Zofran, Phenergan for breakthrough. Took away the Phenergan because of sedation. We added Decadron and scopolamine, all in on the carb loading the night before and the morning of. We were using Foley catheters for all our bypasses. Gone, no catheters. Went from local injections only to adding tap blocks to our local. Backing off on a Novant peritoneum, again, all about decreasing the stress response of the surgery. Using Valsalvas to get out some of that extra gas. Advancing our diets more rapidly, and then adding some stool softener. But despite all those changes, we looked at our data a couple of months later and said, you know what? We're not moving the needle on post-op nausea vomiting, believe it or not. Our patients are looking like this. We need to figure out something else. So looking at things, looking at the literature, looking at other service lines and things we're doing, we made some changes with post-op vomiting, added Haldol, added a liter bolus, again, getting into the weeds a little bit with bariatric surgery. Everybody gets a liver-shrinking, ketogenic diet 2 weeks prior to surgery. What we realize, as those of you familiar with the ketogenic diet knows, they lose a lot of water weight initially, right? That glycogen changing, and so they're losing a lot of water. So while we didn't bowel prep, our patients were inherently dehydrated. So we added fluid back, added Haldol, and lo and behold, and we also dropped our doses of Toradol. We had seen some bumps in some elevated creatinines, and lo and behold, it worked. Here's our data. Post-op nausea and vomiting dropped through the roof, 63%, 27%. Opioid use on the floor, 100% to 43%. A length of stay, we're doing pretty good, 1.95, dropped it down to a day. Percentage of discharge on day one, look at that. I mean, 30% to 93%. I mean, are you kidding me? I mean, if people aren't doing this around the country, what are we doing? I mean, it's dramatic. All statistically significant. This is a cohort, by the way, that we compared 520 that we did before the ERAS program started and 520 that we did after. And so that's the numbers we're comparing. And then also all the post-op things, complications, 30-day readmissions, reinterventions, all stayed the same, right? So again, our outcomes are the same, but yet our post-op nausea vomiting opioid use is spectacularly better. So we're happy. And I will also put in a plug anecdotally that our patients were ready to go post-op day one, more awake and alert, more mobile, huge for our patients. I'm running short of time, so I'm going to kind of hit some of these things briefly. Keys to implementation went over a lot yesterday, but patient as a partner, you need navigators or patient education coordinator, teamwork, multi-departmental. This ERAS patient identifier is really another thing crucial that we found in our hospital, and having a Vicky helps as well. Just a couple of things we're doing as we in the future. We are looking at efficiencies now. We feel our protocols are pretty good, so how do we be more efficient with our tap blocks, turnover times, OR efficiency, and at the bottom, how can we trim hospital and case cost? We are pulling out our current post-op nausea vomiting cohort, really drilling down, is there anything else we can do that we haven't already done, and also working with some other agents to add. And on this, ERAS 2.0, after listening to a lot of things yesterday, I had to throw this slide in on where I think we need to go. And EPBOM is doing a wonderful job with helping get enhanced recovery, get to standard of care by teaching, guidelines, implementation, developing data, both clinical and corporate, right? We got to convince corporate and administration. We got to publish, and others other than anesthesia and colorectal who've done a spectacular job. Dan and I, and Dan is doing it, and we're right behind him. We got to publish in our specialties too. We need to get more attention to what enhanced recovery can do. One of the things you're going to hear all day today is developing the science behind what we're doing. EPBOM is doing a wonderful job. And here's just my plug for where we go next. We're in enhanced recovery now. This group is doing a great job of expanding that, not just to what's happening in the hospital, what's happening perioperatively, right? That's next. But ultimately, it's all about surgical optimization. It's that whole course. Why aren't we doing balance and flexibility and resistance training with our elderly patients before and after surgery? Why aren't we collaborating, as we are doing with the orthopedic surgeons, to get that patient's BMI less than 40 before they even had that total joint, which you know is going to have complications afterwards? Why aren't we looking at that whole breadth of care to optimize everything across the board? So I think that's what our next challenge is going to be, is take it from what we're doing in the hospital to perioperative care and broaden even more. And quite frankly, I think that's the way we're going to get paid in the future as we go to value-based care. Thank you. Sorry I ran over.
Nick Majerison here. Thank you for listening to TopMedTalk. Now, make sure you've subscribed to TopMedTalk on your podcatcher or however it is that you're listening to us at the moment. And you're spoiled for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Have a look, topmedtalk.com.